Well, you're very welcome to this unusual video talk. Now, many nurses and doctors in the NHS have been greatly challenged over the past 18 months now, really, and many individuals have really risen to the occasion. They've upped their game and stepped up to the plate, and two of those I'm talking to tonight. And one is Dr. Rebecca Hall, and the other is Dr. Mary Valentine. So Doctors Hall and Valentine, you're very welcome to this chat. Now, the background here is you've been instigating a new form of remote assessment, which we're going to talk about. But first of all, I'd like to talk about the general principles, because we've learned so much about this new disease. I mean, if we think back to January 2020, we didn't know anything about COVID-19 and SARS coronavirus 2. But now, you two at least have amassed a very significant amount of expertise. But Becca, if you wouldn't mind starting us off, what common symptoms are people complaining of when they develop COVID-19?
Thanks, John. Hi, nice to be here. Well, I'll just give you a little bit of a background, because Mary and I work for the Central COVID 111 team, who and our patients come to us via the 111 system. And so they are triaged automatically by an algorithmic system, which is either a phone call where they talk to a call handler, or an online system. And so already they've already been filtered to have certain symptoms. So those symptoms that tick the boxes to end up speaking to us are cough, fever, and smell or taste change. And I think they added in shortness of breath in at some point in the last year as well. But as you know, and as we all know, COVID covers an awful lot of other things. And we certainly found that there was a multitude of symptoms, and the commoner ones that weren't cough, fever, and some kind of smell or taste disturbance were aches and pains, shivers rather than specifically a fever, feeling really tired, sore throat, headache, feeling really ill, actually, just feeling ill. But because COVID covers everything from asymptomatic to dying, basically the degree of symptoms really varied, and also the actual symptoms, and there were a whole load of symptoms.
So we're dealing with a syndrome here, aren't we? A whole mass of possible presentations and a whole range of severities. So Mary, what would concern you particularly if a patient reported some particular symptoms, what we might call red flag symptoms? What would make you think, oh, just a minute, I'm not sure I'm happy with this patient?
Part of it depends on where they are in the timeline of their condition. So we know that you can feel pretty rubbish in the first 2 or 3 days of it, but it's unusual to be desperately unwell in that time, from the point of view of are you likely to need to be in hospital or anything like that. So we kind of look a little bit at the trajectory, and if you're day 5+, then that's when we start to be thinking, should we be more concerned about the symptoms in this particular person. So most people will be starting to improve day 5 to 7. A lot of people are not better, and I think on average most people will take about 2 weeks to get better. And so a lot of people are just very depressed, upset that it's taking so long to get better, when they need to going back to work, and the 10 days isolation should mean in their heads that they're better now, but they aren't. But what we're most concerned about are people that are getting worse at that stage. So you might be 5, 7, 10 days, but you're kind of taking a bit of a dive. So that's a red flag to us. But in particular, breathing is very commonly something that people suffer badly from. And the breathlessness, we're concerned if it's worsening. So that if you find you can't do what you could do yesterday because you're more breathless. So you're looking at how quickly is that breathlessness worsening, and is it on a downward spiral rather than beginning to improve. But some people can have quite low oxygen levels, even though they're not particularly breathless. And the symptoms that to us are most concerning there are if you're basically feeling much worse in yourself, got less energy, you're not able to do the things you were doing yesterday, your muscle aches and pains are really bad, you're dizzy if you get up and walk around, you might be getting a bit dehydrated, you might have had a high temperature for a while, and not being able to keep up with your fluid intake because you haven't got enough energy to. So your urine output might be going down. Some people start to get confused or muddled in thinking, so brain fog's really quite common, and that can be quite early, but that when it comes on later, that can be a sign of hypoxia as well. So brain fog, dizziness, confusion, and different ages, different things.
What does hypoxia mean, Mary?
Hypoxia is low oxygen levels. And you know, it is one of those things that we will quite often feel that we need to get someone checked out just because we need to get their oxygen levels measured. And when we are assessing somebody, we'll quite often ask if they've got anything in the house that they can do to take any measurements for us. And anything might be another person to help, but it might also be, have they got a thermometer? Have they got a blood pressure meter? Have they got a pulse oximeter? Lots of people have all sorts of things which they didn't used to have, and lots of people don't have really basic stuff.
Indeed. So really, I think what you're saying is it's not so much the snapshot; it's the trend, the way things are going.
Yeah.
So, but Becca, we talked about this idea of triage. But what do we mean by triage in this context?
Well, in this context, we had a choice of what we can do with patients. We can keep them at home and give them advice about managing symptoms at home. We can refer them on to see somebody where they could be seen face to face, because all of this is done over the phone. Or we could actually admit them directly to hospital. And on our system, we actually had a button you pressed which called an ambulance, and then you'd have to just decide what category of ambulance, you know, whether they needed a 999 ambulance then to come right away, or whether they could wait 30 minutes, 2 hours. And at the height of the pandemic, people were waiting 4 or 5 hours for ambulances. And so we had to bear that in mind when we were assessing them, that actually a lot of these things were changing during the course of the different waves we had.
Right, interesting. Yeah.
So those are our choices. John, yeah. Keep them at home, see somebody else, or to send them straight to hospital.
I would, if I was talking to you, I'd find that reassuring that my doctor had the power to, if they were worried about me, that they could call me an ambulance straight away. That would be, I would find that actually quite reassuring, I think. So Mary,
and it was often something actually at the beginning of the.
Sorry, go ahead.
I was just going to say, it's often something at the beginning of the call, you'd say, this is what we can do. You know, we can't do an awful lot, but this is what we can do. And together we'll make a plan together, and, you know, with what we think is most appropriate for you.
No, that's great. Mary, you said you're not too worried usually about the first 5 days. So it's like this is a phased illness. So are you seeing like a viral phase followed by a potential deterioration phase? What's the evolution of this illness?
A lot of people just start when think they've got a bit of a cold. And when we first were looking at this, we were coming up with the basic symptoms of the fever and the cough and the altered taste and smell. The Zoe app was really good at helping to pick up symptoms in people. And even prior to that coming out, we have a forum where we can actually compare notes and chat to each other, and we were noticing various things at the beginning which other people hadn't been talking about. So a lot of people would have maybe a stomach upsets like diarrhea for a day or so before they started getting the symptoms of, you know, sore throats and fevers and feeling fluey, achy all over. The taste and smell, that's often a few days later. Sometimes it can be as much as a week later. And I think the theory now is that that's got a different process. It's with the virus affecting the nervous system at that stage, starting to cause those sorts of symptoms, like it might with the confusion and things later on. So yeah, it seems to be acute symptoms which are a bit like the flu, and then other symptoms that start coming in later, and there are various different causes for them. So the breathlessness might just be the COVID affecting the lungs, but it could also be that it's starting to cause clotting problems and people are getting clots on their lungs, which when that happens, it's normally a big step change. But it's so, which is why we're very much looking at how quickly has this changed? Have you suddenly become a lot more breathless? Or are you breathless over the last hour, over the last day, over the last 2 or 3 days? Have you got any other things going on as well? You know, because obviously people do not just have one condition. They are a whole amalgam of everything else that happens to their health generally.
So typically, if someone is going to deteriorate to the point where they would need to be hospitalized, how many days have you found that is usually after the onset of initial symptoms?
It's 7 or 8 days, maybe
Right.
10 days, that sort of time frame.
And when are people kind of in the clear from the risk of hospitalization, or is it not that simple?
I think if you get as far as 2 weeks, you're pretty unlikely to be getting worse from the COVID at that stage. You'd normally be, over the 2 or 3 days before that. So we do obviously speak to lots of people who are more than 2 weeks, but they're normally telling us that actually they're still feeling rough, but they're not as bad as they were 2 or 3 days ago. Would you agree, Becca?
I do agree with, I think that's our experience, Mary, but we are hearing more that people are being re-hospitalized and even dying, some weeks after the initial illness. And I'm not sure that they're all from, we don't know what they're all from, but so I think it's quite difficult. I mean, I think you have to have a period of to be actually better, to think this person is better. Some people are taking a long time to recover completely.
Do you think there's a lot of secondary bacterial infection, Mary? Mary, take that one. Do you think there's a lot of bacterial secondary infection after the initial viral infection?
Yeah, I think initially people thought that there was. And so we were being advised that if somebody started to cough up green stuff and it was 10 days down the line, then have some antibiotics. But I think the evidence for that has not been that high. So they have been doing, like Principal trial has been doing things looking at giving antibiotics earlier on in it, and they've not found that that's made any difference.
Interesting.
So I think it's something we have to think about. So if somebody's improved and then they start coughing up lots of green stuff and they've got high temperature, then it's never say never, is it?
And if you wanted to order blood tests to confirm it was a bacterial infection, would you have to refer them to the local surgery, or how would you do that?
I'm not sure that's how you would normally make that decision. If we're sort of asking for somebody to be seen, it's basically to somebody to eyeball that person and say, are they safe?
Yes.
And you may be able to hear certain things on somebody's chest that would make it sound as though it's more likely to be bacterial. If they were sufficiently bad, they may well be going to the hospital and having x-rays, which might show a bacterial infection. But wouldn't normally be doing blood tests for that, would we, Rebecca?
No, and it tended to come from the history, John, because very few people actually were coughing up anything. It was really quite unusual to be coughing up sputum of any kind when they have COVID. That was my experience. And if they did have, yucky green sputum with some blood in it, or just yucky green sputum, I might consider antibiotics then, depending on what else was happening. And of course, a lot of people have asthma or have had childhood asthma, and so that often you're not just dealing with pure COVID, you're dealing with COVID on the background of something else. And initially, early on in the pandemic, there was a lot of concern about asthmatics, which I think is I don't think there's much evidence that asthmatics get COVID worse now, which is great. But there was a lot of concern initially, so I think a lot of people got treated. A lot of asthmatics got treated with steroids and antibiotics in those early days when they had COVID.
Mm-hmm. Yeah, so it's my fault. My last 3 years clinical work was on A&E, where we do blood tests for absolutely everything. But that's an interesting point, Becca. The cough is not very productive in COVID. That's
it can be.
It can be.
Yeah, right. It can be. But it's one of those, classically it's a dry, continuous sort of cough, but actually a lot of people are coughing stuff up. It's probably not normally quite so mucky.
Mm-hmm. So
it can be quite quite distressing. The cough can sometimes be the thing that means they can't catch their breath. They can be coughing so much that they can't sleep, that they can't lie down. Every time they lie down, they cough, and it can be as a symptom really, really disabling. And I found myself often prescribing Folcodeine Linctus just to stop them coughing, so that they could relax a bit, because they would have great spasms of coughing, which was stopping them doing anything else. And often they didn't have many other symptoms, just terrible cough.
So literally like coughing fits, Becca, where they just cough for minutes at a time.
And sometimes I'm doing vomiting, like whooping cough.
Yeah.
Oh, right, okay. So the coughing can actually cause vomiting. It's so severe.
And I think that's one of the things with the cough, it can make them so breathless. So when you're asking about the breathlessness, one of the things we tend to ask is, are you breathless just when you're coughing? Or is it you're breathless in between the coughing as well?
Yeah. But Becca, how does the work that you do here tie in with testing? Do you send patients for testing, or how does that work?
It's really interesting now. This service is still running now. And people are, the advice hasn't changed. If you have a cough, a fever, or alteration in your taste or smell, you should get a COVID test. And at the moment, people are finding that quite hard to get their heads around. They don't like that because they perceive themselves to be at very low risk now, because they're hearing the figures are going down. It's the lowest it's been since September the 2nd last year, and they don't perceive themselves to be much at risk. And they've decided they've got something else, because the inconvenience of getting a test and isolating is significant, as we all know.
Yes.
But certainly we've been through, this has really evolved, because when we first started doing this job, there wasn't really any community testing. There was only testing people who were admitted to hospital. And then gradually test and trace started happening. And then there was that time you had to drive, you're in Edinburgh and you press the button on the computer to get a test, and it said drive to Swansea. And there was outrage, and we were all trying to, and I was saying, try it in 5 minutes time. And then there was a message went out, if you try 8 o'clock at night, maybe you can get a test for the next day then. And so we were all desperately trying to help these poor patients to get a test. And sometimes I was thinking, is this really in their interest to get a test? We were making clinical diagnoses all the time saying, I think you've got COVID. And I would sometimes say, they say, I need to get a test. And I would say, no, I think you've got COVID. And I thought, is the test just, is it just a sort of statistical exercise to help the government organise, know exactly what's happening? But so often they didn't get tested. But we were making clinical decisions that things were COVID right through. Yeah, but that was the getting the PCR test was pretty much the only investigation we would do. Yeah.
No, that's great. You can diagnose clinically. That's exactly what you were doing. That's great.
And the big thing about that is you're basically saying you need to do the isolating, and your household needs to do the isolating. So the advantage of getting a proper test is if it's negative and you've got a low chance of it really being positive, then that means you then don't have to do the isolating. But if it comes back positive, you really do know you need to. I think we're now getting a bit of confusion, because people have got the lateral flow tests. And so they think, well, it's all right, I've done a test, I'm negative. But the lateral flow tests are not validated for people with symptoms. They're to pick up people who haven't got symptoms, who may be infectious.
Yes.
And so one of the things we're finding is that we're then saying, well, when you did the test, how long was it before you got the answer? And if they say, oh, I did it and it came back in half an hour, they need to get another test done.
Yeah. But Becca, what sort of changes have you noticed now that the vaccination program is progressing nicely?
You know, that's been really interesting. We're very aware of the when Mary and I are sitting in our different houses doing our, on our shift together. Sometimes there's 100 doctors on a shift, and we are all looking at the same queue of people, and we can see just a quick profile. We can see their name and their age, and so we're all aware of. We basically we're aware of all the people waiting on that list in 111, and what I really noticed was that the age, there were very few over 80s coming through in sort of February, March, and since then the ages have definitely come down. I mean, now there's actually not that many patients coming through, so I'm not sure it's terribly valid anymore. But that was my experience of noticing the vaccine, as well as having done lots of vaccinations, which of course was a lovely thing to be part of.
Yeah, indeed. So basically, the older people who had been vaccinated were reporting 111 less frequently as the vaccines were sort of kicking in. Is that the?
Definitely.
Yeah. Interesting. Yeah. Mary, what sort of advice do you give to these patients?
It depends where they are, but so basically the first line is how to manage their symptoms, and so from that point of view, provided that they don't have any other intercurrent illnesses, so they might, for example, be on certain medications or that you might want to give advice about as well. But in the general run of things, you'll be looking at managing your symptoms. So if you're feeling achy all over and really rough, then paracetamol or ibuprofen might make you feel better. If you've got a really bad sore throat, then sore throat lozenges. If you've got a cough which is really causing you lots of problems, drinking plenty for either of those. But also, if it's a really disabling cough, then something with codeine in it, like Volcadine Linctus, can be really helpful. There are certain other things that can help, like making sure we've got fresh air. So if you're feeling a bit breathless with things, then fresh air often helps. If people are finding problems with their breathing, then they found quite early on that why they prone people in hospital is they seem to be able to expand their lungs better if you lie on your front for a bit or on your side rather than lying flat on your back.
So that's all prone means, is it? Just lying on your tummy?
Lying on your tummy, yeah.
And that seems to help breathing.
And it seems to help breathing. And it's something that we haven't really talked about before with other people with chest infections. We tend to say, well, sit up if that helps with your breathing or whatever. But we haven't been telling people to lie on their front. So it's something that's new that's come out with this. So that's kind of the basic with your symptoms, making sure that you're still peeing 2 or 3 times a day, that you're having 6 to 8 cups of water a day to make sure you're keeping yourself well hydrated. But then it's also what things to look out for. And so the sorts of things that we're saying are, okay, if it's somebody at the beginning of their illness, to say we would expect you to start improving at about a week, 5 to 10 days. But if you find that you're going the wrong way at that stage, then you need to be contacting us again so that we can talk through things and find out how you are at that stage. And if at any stage in between you feel as though you're worried about yourself, you're unhappy, you're scared, it's pick up that phone and talk to us. But it's going through those red flags. So if you are finding that your breathing is getting worse, that you're more breathless, especially if it's just walking around the room, going to the bathroom, talking, if you're finding that you're feeling really exhausted and struggling to get out of bed, struggling to go to the bathroom, if you're feeling muddled in your brain, you feel as though you're not thinking straight, if you're feeling dizzy when you're standing up, if you basically feel as though you're getting worse, we want to know.
So that's basically very thorough safety netting, isn't it? So you're catching the patient if anything goes wrong. There was a lot of
partly giving people permission to contact us again, because people kind of feel once they've asked and they've been told, then they should just get on with it. But with this condition, you can change very quickly, and it's really important that people know that if they've been advised one thing, if things change, they need to revisit it.
Yes. Yeah, I think that's input the permission to come back to you. Sorry, Becca, go on.
I just wanted to add about stuff. I just also we were doing a lot of advising and supporting people, really talking about reducing the risk of onward transmission, because of course we needed to talk about how they might practically do that in their house, and sometimes you'd go into quite a lot of detail about how to isolate properly, because I would consider isolating themselves within the household, but also isolating the household from the rest of society. And actually doing that's really challenging. And it doesn't cost a lot of money, but talking about opening windows, like you say, Mary, having fresh air, using a mask when they could around the house, but also reducing the risk to other people. Just explaining how it works and how best to reduce that risk. And I would always say, if there was an ambulance coming, I would say, look, throw open the windows, to reduce the risk to these poor paramedics who are coming to help. Because I think opening the windows was a big thing and really important.
Yeah, I think that's a vital role, actually, that you're actually, as well as helping the individual, you are preventing the spread of the pandemic by giving that kind of advice.
And we'd also try and signpost to community support, because of course, once you were giving this bad news to them that they really needed to isolate as a household for 10 days, they needed to understand how to, what they needed to tell their employer, and how, and you'd have to explore how they were actually, did they have food in the house? Did they have medicines? How were they going to get hold of medicines? Because of course we can really help them with local support. There were lots of things set up, weren't there, to get the support they needed, but sometimes they just needed a bit of support in doing that because they're feeling so dreadful.
And that's one of the other things. It's when you've got other people in the household, you're worried about them and that they're not spreading things, but there are an awful lot of people who live on their own, and so we're really aware of the vulnerability of people that live on their own when they're unwell. And I can remember very early on, in the very early days, I had somebody had phoned up and she'd got to about day 12, 14, and she'd found the note she'd left on the kitchen table when she was feeling so awful that people would know that there was an animal that needed feeding somewhere. Yeah, and she had no memory of writing it, but she was so unwell that she'd actually kind of written her last will comments to the world that found her. And so yeah, do you live on your own? So make sure somebody knows that you're unwell. Make sure you have a system with them, that you touch base with them 2 or 3 times a day, and if they don't hear from you, that they contact you. Indeed. Really basic stuff. Yeah,
it is, but you've got to think of it and itemize it, otherwise it can get missed. Mary, sorry, maybe while you're there, does COVID mess up other long-term conditions? Like, can it destabilize diabetes or COPD or chronic heart disease? And I mean, we know that people with these long-term conditions can get more severe COVID, but can the COVID destabilize patients as well?
I think anybody that's got diabetes who becomes unwell, their sugars tend to go up. And if somebody's not eating, then they tend to eat less. So that can be really quite important with diabetes, because people often think, I'm not eating, therefore I shouldn't have as much of my medication. But they need to be monitoring these things. But the other thing is, there are certain medications which we know that if you're getting dehydrated, you should be avoiding. And so things like metformin for diabetes, certain blood pressure tablets, or water tablets, certain tablets for pain, for example, like non-steroidals. If you might possibly be getting a bit dehydrated, then you shouldn't be taking those. So it's one of the things we do is to check what other things people have got going on and what medication they're on, so that if there is something that we need to advise them on, we can do so. Quite surprisingly, a bit like with the asthma, we're really expecting people with COPD to get quite bad with this. And it seems as though they haven't ended up going on to intensive care units as much as we thought they might. And that led to the principal trial doing the study with looking at steroid inhalers And is that one of the issues which might make a difference to people with COVID?
Mm-hmm.
And I think they're now looking at recommending them for the people over the age of 65 or with certain other conditions. That it might be a good idea to help reduce the admission rates.
So there's quite a few things there where you do need quite a high degree of medical expertise to give the right advice. I think the last question I've got about the disease in general is, Becca, you might want to take this one. Recovery times and how long is it that people are suffering from this? We've heard about long COVID, sort of maybe beyond the first sort of 10 days. What are you typically seeing and how many patients tend to get worse? Not so much particular numbers and figures, but, generally the experience of people.
I think there's a big range, John, and it partly depends on how bad you've been, and certainly the people who've been very bad, who've been in ICU, it can take up to a year to recover from any illness that you've had to go to ICU for. I don't think that's a big surprise, but we have seen some people who haven't been particularly ill in the acute phase just not really get better. There's a big range of people who are not recovering so quickly. They've named it long COVID, and some of them, I think long COVID is now defined as symptoms going on for more than 4 weeks. Which covers a lot of people, and some people seem to have COVID type symptoms that weren't particularly ill at the time though, which is quite different from the ICU sort of group of people.
Yes, as if there's two completely sorts of sequelae, really. Those that are just caused by the patient being very ill, like the intensive care syndrome, but something that we're still learning about COVID, really, that's idiosyncratic to the COVID disease that can cause longer term problems.
And it seems
it does seem to be an immunological, differences in how people react immunologically, and how. And that seems to be the big thing. We don't really know an awful lot about it.
I was just going to say whereas with the acute illness where people end up in hospital, that seems age is the biggest risk for that. The long COVID symptoms seem to be fairly evenly distributed, from my understanding of it. Is that your understanding, Becca?
Well, I think there tends to be more, slightly more women and slightly more middle-aged people with presenting long COVID symptoms. Yes, and there even have to be children. I've spoken to a few families where the mum's got it and 2 children have got it, for example. So I think we're going to discover that there is a genetic component probably to whether you get long-term symptoms in this kind of picture, really.
I've never heard that observation before, Becca. That's interesting. Yeah. Mm-hmm. Well, Dr. Rebecca Hall and Dr. Mary Valentine, I think that's probably the first part of this that we've talked about. So we need to go on now and talk about your new innovation, really, which is remote assessment.